We had the Exoskin vest that allowed you to record your heartbeat, how you breathe, and movement and other things. So plus, we do the brain check with an iPad before and after, and collecting blood, saliva, and other things. So it's quite demanding, but I think we were able to fulfill what was asked from me and my team is about, yes, can we provoke relatively safely PAM? The answer is yes. We have tested the 403 cases since 2015 just for ME, and we have over 80 something control, and just for the long COVID, we have another cohort of 60 individuals that we follow every 3 months over a year so far. So it's a lot of testing. So roughly we test over 500 individuals over the last 10 years, and we never had to call 911 from home.
Welcome to the Dr. Eleanor Stein podcast. In this show, you will hear expert medical professionals, researchers, and people with lived experience share science-based, low to no cost strategies to help people with complex chronic diseases. Listen in for another dose of education, empowerment, and hope. Hi, everybody. I'm Dr. Ellie Stein, and welcome to the Dr. Eleanor Stein podcast. Here, I bring together diverse and sometimes challenging views about complex chronic diseases. Today, I'm thrilled to introduce you to Dr. Alain Moreau. He is a research scientist who, in my opinion, has really put ME research on the map in Canada. Every time I speak with Alain, I find him inspiring and forward-thinking, really a visionary in the field. In this episode, you're going to hear about how he got interested in ME in the first place, about the network, the research organization of which he is the director, called ICanCME, and finally about his own very exciting research. So I'm going to go a little bit into depth about Dr. Moreau's biography so you kind of get a sense of the breadth of his knowledge and his work. He's one of the few scientists today who continues to have broad interests and doesn't subspecialize, and he's creative enough to apply his expertise in molecular genetics and related fields to a wide range of disorders. He's a full professor in the Faculty of Dentistry, Stomatology Department at the Université de Montréal, and he's cross-appointed in biochemistry and molecular medicine as well. I first met Dr. Moreau in 2016 when he was just starting to pull people together to apply for a big network grant from the CIHR. It took some perseverance for sure, but he was successful in 2019, and the interdisciplinary Canadian Collaborative Myalgic Encephalomyelitis Research Network, which we, for obvious reasons, call ICanCME, was funded. He, in his own right, is an internationally recognized expert in molecular genetics of pediatric scoliosis. His discoveries have led to multiple, often cited peer-reviewed papers, as well as 72 patents covering innovative diagnostic tests and therapeutic molecules. I just learned this today as I was updating my my research on Dr. Moreau, that he's also the co-founder and chief scientific officer of a startup in Montreal called Inception Therapeutic Inc. And they're actually developing diagnostic tests and disease-modifying drugs for osteoarthritis. So as someone who's starting to develop that disease, I'm very interested to learn more. Dr. Moreau has 158 publications and counting, and over 3,500 citations. In our field of ME, he's best known for his top 100 paper in the influential journal Scientific Reports. It's called Profiling of Circulating MicroRNAs in ME and Their Relation to Symptom Severity and Disease Pathophysiology. Now, I'm going to get him a little bit later to explain what microRNAs are and why he thinks they're so important. He followed that with a paper that I think is really groundbreaking, which is a way to discriminate ME from fibromyalgia and other comorbid conditions. And he recently published a paper on the neurocognitive consequences of post-exertional malaise, all very important topics. So Dr. Moreau, thank you. Welcome to the podcast, and thank you for taking your time to do it.
Thank you, Eli, for the invitation, and I'm also thrilled to be part of your podcast series.
Thank you so much. So I'm going to start with a personal question, which is, for someone who is in the Faculty of Dentistry and studying stromal health, how did you become interested in ME?
First of all, let me just reiterate that my main expertise is molecular genetics of complex diseases and mainly musculoskeletal diseases. So, and I'm really fully appointed as full professor in both faculties, so medicine and dentistry. Although, as you said correctly, dentistry is my primary affiliation. So there's a strong connection in Faculty of Dentistry and Oral Health with connective tissues, calcified tissues. So for someone that's been trained in bone biology and bone genetics, was natural for me to being a recruit and develop my career, my academic career at the Faculty of Dentistry. So like many other colleagues, so dentistry shouldn't be viewed as simply dental health or dental processes, but it's way beyond oral health. And we used to say that healthy mouth, healthy body.
Right. Yeah, thanks for that correction. And so how did you then shift, though, from that into ME research?
Yes, so I started in 2000 at Saint-Justin University Hospital, called CHU Saint-Justin, which, as you may know, is the largest mother and child hospital in Canada, and being recruited to work on scoliosis. So we had in that time very talented and still a spine surgeon and engineers, but nobody really studying what is happening in the spine, and I was the first being recruited to really address that, and from that I developed, I think, a successful research program, which is still very active. We just published recently 2 very exciting papers in 2025, and most of my patents are associated with the development of different diagnostic tests to predict the risk of scoliosis progression. And I think we achieved more recently this success, which is also related to in one of our recent papers. Having said that, I had the opportunity to serve as the Director of Research and Chief Scientific Officer at Saint-Justin Hospital. And when I was in such a function, being approached by a friend who were involved in a private foundation where they were interested to support research on CFS, but they brought me in as a kind of volunteer consultant to address what do we know and where this field is going, and make some recommendation in my report. So I did that, and I started to be very fascinated because Myalgic Encephalomyelitis, as you know, is another disease affecting millions worldwide. Very serious symptoms, okay? Highly debilitating condition, and nobody at that time really was able to decode the disease, and that was explained at that time, and maybe it's still the case, that by the lack of funding. So which means that many studies were reporting a complex disease with few cases, with few matched so-called healthy control, and nobody were able to reproduce anything, and that was where I jump in. So following my report, I asked them the permission, say, listen, I find so fascinating the disease and the challenge. So I would like to propose something. Give me a few weeks, I will come back to you, and there is no string attached. If you don't like the project, there was no termination, nothing, there is nothing. So, but I will try to start with something. And I was able to convince these private foundations to support my work, and that's why I start in 2015. And I think you omit also to mention to your audience that you play also a very pivotal role in establishing ICanCME Research Network, because you were the first really one Canadian that introduced me to other fellow Canadians doing research before me in the field. When we have this meeting in Fort Lauderdale, that was my very first
That's right.
time. And I remember one very famous dinner that that you organized and invited a lot of Canadian fellows, and that was really the moments that ICanCME, even though that at that time we didn't have the name, that start to be created. So you're a co-founder of this network, like many others. Thank you.
Thank you. I didn't know that had an influence. That's really great to know. Yes, every meeting I would try to host a dinner for all the Canadians, so that we could get to know each other. So just moving into a little bit more about ICanCME, the mission, as it says on the website, is to be the primary resource for initiating, supporting, and sustaining innovative and collaborative ME research designed to benefit the health of all Canadians with ME and those at risk of developing ME. I'm wondering if you can share a little bit about, I think a lot of how the network got set up was kind of your vision, like the different components that you felt was important to move things ahead. So I'm wondering if you can just talk a little bit about the structure.
Yes, so as a national research network funded and supported by the Canadian Institute of Health Research, we not only put on the map ME research in Canada, having this recognition, but we start to be better organized and also being used as a voice for patients living with ME CFS, as well as caregivers and other scientists. And we are a very small research community across Canada, although the patients is a huge community. Today, I think we were beyond 1 million Canadians suffering of ME.
Wow.
Certainly, unfortunately, due to the long COVID and the COVID pandemics that resulted to an increased number of individuals suffering of ME/CFS. So the number is not declining, but we still have some issues. How can we attract the next generation of scientists or clinical scientists in the field is difficult, okay? And you will see, especially at the south of our frontier, that in the United States that will also be more difficult due to change of the NIH and other granting agencies. So it's difficult. There are so many complex chronic diseases, but ME is challenging. ME is real and is affect millions of individuals. So we need to have this national research network. We recently renewed our network funding.
Congratulations.
And that's why we often, you may heard, ICanCME 2.0. And what is quite distinctive as a national research network is that patients with live experience and true patient leaders, okay, often you heard about patient partners or patient as participants, but now we have patient leaders. And I really insist on this knowledge and notion because they are across the board, across our governance. So, and we are really supporting the principle about never about us without us. So that's why ICanCME has been selected by patient partners that represent what they are looking for from such a national network, that we give them a voice. We brought forward a research vision, a strong research agenda. And from ICanCME, the original version and 2.0, I think we really trust this building on our previous accomplishment and working hands in hands with patient partner, caregiver, research scientists, and clinicians to eventually find a cure for this terrible disease.
Yeah, I think that's a real strength of ICanCME. The patients are not just kind of wallpaper. They're leading committees. They're on every level, executive committee, steering committee. It's really fantastic. Just moving into the science aspect, I noticed on the website right now, there's 3 projects that are kind of your core funded projects. I don't know if you want to say anything about those projects.
Yeah, the core project, I just want to also explain that when we create in 2019, in September 2019, ICanCME, we never know that the pandemic was coming.
Right.
So that creates a
Surprise.
lot of delays in the realization in the way that we develop our activities, like many other research networks. So that impair many of our researchers. So that creates some delay. So we start with 3 core projects. 2 of them are still on their investigation, if I may say. Okay, a third one has been completed recently by Dr. Lindy, and we are in the process to revise a manuscript that's been stemming out from the work. This manuscript showcased that there are some very subgroup of ME patients associated with immune impairments that are very different between the groups. So that would be a very interesting paper, I would say. It's not novel because others, by different approaches, also I've seen that. What is novel is the investigation led by Dr. Lindy in Alberta. They use our microRNA classifications to subgroup the patients. And that eliminate different new possibilities for treatment. Okay, of course, it's possibilities that awaits further preclinical and eventually through clinical trial evaluation, but at least we have this new elimination. If you put all the patients together, you lose traction, you lose this vision,
Right.
and having this stratification is really helping us, and I hope patients eventually, toward more personalized and specific treatment that will be safe and efficient. So that's 2 important keywords here. So the other two core project, one is by Dr. Lee, who is now moved in San Antonio, Texas, and the other one is by Dr. Louis Knuckles in Vancouver. So they are still progressing, and I hope that they must be completed by the end of this year. So this is from the initial core project. We had multiple smaller pilot projects that we call New Frontier ME Discovery Grant, where we created and sustained new research teams, so newcomers in the field. So and you will start to hear of them probably before the end of this year. So it takes time to start from scratch something new, but we cover quite a spectrum of different type of research involving experts from different disciplines, from genetics, looking at familial cases of ME versus microbiota and other changes in relation with the very specific measurement of the diet. So from Dr. Marcel and other signaling molecules. So you will start to see the very first publication emerging from ICanCME 1.0 from the support that we give for this new frontier. We will maintain the New Frontier program for the ICanCME 2.0. We are not ready yet to launch the next competition that will come in the upcoming months. So because this is one of the most interesting program to attract newcomers. We are well aware that it's not a lot of money, but that can make a difference to finalize or start a proof of concept of something new that will be used as a stepping stone, if you wish, to attract more funding. We have also, we were being quite successful lately with our ME Stars of Tomorrow, so bursaries for graduate students. and a new competition will be launched soon. And these students and new faculty members, we want to regroup them in a virtual academy, and we use the very English
Yeah.
wording of academy with ME, not MY. And we hope to eventually rally other organizations in UK, USA, Europe to build this larger virtual academy to promote the best knowledge possible around ME and the best practices, and also to nurture and sustain the next generation. This is a true challenge because every time we are losing seasoned clinicians that retired, and you are one of them in Canada, by the way, we cannot even replace you. Okay, so we need to be more aggressive in a positive sense here to make sure that we can attract people and also work with the funding organization from CHR, of course, and others, but also private sector to further sustain them. It's one thing to bring and create the right environment conditions to attract them, but if we don't put more money, we will lose them, especially when you are a junior faculty member. It's so critical that you attract in the first 2-3 years of your career a first major grant. Sometimes they ask you to have your own salary award. So we need to make sure that we put them in the most successful condition. But at the same time, we want to attract also other experts from other fields that they did not realize that they have maybe some expertise or tools in their hands that can be applicable to solve the enigma of ME. So all in all, we are working there. And I hope that with our friends and partners, we can make a difference.
Do you have a sense, Dr. Moreau, how many new people, including faculty and students in Canada, have entered the field or at least are partially working on ME?
Enter the field, it's difficult to say because you can always attract and fund them. But I would say that because the New Frontier Grant is around teams, so definitively with the first waves of New Frontier, we may have over 60 new people working on that field. We have more than a dozen of students. I remind you that with the ME Stars of Tomorrow, we are also awarding bursaries for brightest Canadians studying also in other countries. So we have people in Netherlands right now. We have someone else in Oxford University. And this is something that I really want to promote. That we are welcoming foreign international students to come in Canada in the best ME labs, as well as to allow Canadians to study in the best international lab working on ME. So we have new partnership to sustain that through ICanCME 2.0, but that I think is the best way to really, again, nurture and sustain talent. And it's something that I'm really pushing because at the end of the day, we cannot do the exchange one-to-one. One is leaving and one is arriving is not a success. So we need to multiply that to make a difference and still benefit from the experience of others before us.
Thank you so much. I just recently was looking at a paper by Rob Woest's, I hope I'm pronouncing that right, his team in the Netherlands, and I saw that the first author of the paper was an ICanCME supported student. So I was like, that was fantastic.
Yes, and that's a great lab. So we're very proud to support Robert and a fellow Canadian student working in his lab, and others will see the example. So that's why the next competition might have more application. That would be a good sign. So those kind of metrics that we are following.
I'm going to ask you again at the end, but since you've kind of talked about some of these competitions, say there's some students listening to this right now, where should they go to see what are the competitions coming up that they could apply for?
We have a website, which has been renewed and modernized, so they can always consult and ICanCME. So just typing ICanCME, you will end up with our website in French and in English. And you can
Perfect.
also contact us at info@ICanCME.ca. So that's the best way that we can provide you the information. But we will do some advertising, and we make sure that when we launch a competition is between the, let's say, CHR competition and other official competition, not
Right.
to annoy researchers to apply at the same time that they have to focus on maybe bigger grant
Yeah.
for the operation of their lab. So we try to be practical in that matter.
Okay. I'd love to move to shift a little bit now to your own research, which I find very exciting, very practical, hopefully in the not too distant future, translating into clinical outcomes. I'm wondering if you can share with people what I think is a very elegant setup to study people who are severely ill and kind of the main components of that ongoing research.
Yeah, thank you for the opportunity to update you a bit. It took us a lot of time to develop our own deep phenotyping protocol to really study, and I approached the disease with really open eyes. So I have no bias about where we should go or how we should put our priorities. And I'm not a specific omic expert, so I use all the omic tools. Okay, those are remain tools, and we shouldn't be slave of our expertise. And to really address what is causing the disease, how can we find solution, and on the more immediate matter, how can we help clinicians to face the challenge, and how can we find maybe some new solutions that nobody really addressed. So we cannot achieve that in silo. We need to work with our largest community as possible. And I benefit from patient expert and patient leaders that they put me, I think, on the right gear at the right time, saying that post-surgical malaise is the key. So I must figure out a way to create post-surgical malaise, even though that we will make patients more sick for a few hours or few days, and something that could be portable, okay, where we can go to investigate housebound patient. As you know, they are rarely participating in any clinical studies because they cannot walk in really, okay? And these individuals cannot do CPET, okay, the cardiopulmonary exercise tests. So we developed this test with the, as you know, the inflatable cuff, and again, a lot of people debate about whether or not the inflatable cuff create post-surgical malaise, or is the sitting create that, or other condition, because it's very impressive. Okay, it's portable machine, but at the same time that we are measuring brain oximetry with electrodes. So you have electrode, you have another machine next to you that beeping. You have the cuff with its own machine. We have the Exoskin vest that allow you to record your heartbeat, how you breathe, and movement and other things. So plus, we do the brain check with a iPad before and after, and collecting blood, saliva, and other things. So it's quite demanding, but I think we were able to fulfill what was asked from me and my team is about, yes, can we provoke relatively safely PEM? The answer is yes. We have tested the 403 cases since 2015 just for ME, and we have over 80 something control, and just for the long COVID, we have another cohort of 60 individuals that we follow every 3 months over a year so far. So it's a lot of testing. So roughly we test over 500 individuals over the last 10 years, and we never had to call 911 from home. So the clinical certified nurse never had to do that, and nobody have to go to an hospital setting or the emergency room following their participation. Are we making them sicker? The answer is yes, and we put that in informed consent. But most of them recovered following the next 5-6 days. A recent study from the group of Betsy Keller and Marian Henson with the CPET, although this group is less affected than my cohort, it took up to 13 days to recover from the CPET with moderately affected individuals. So 5-6 days is not that bad. It's a compromise that we can monitor their health condition, as well as having different biological fluids that we can do some measurement of different biomarkers. So took us some times. You refer to the first two papers that made the top 100 of scientific report, okay, in 2020 and 2023. We have now 6 papers under review or different stage of revision also right now. So you see an acceleration from my work. So we are covering not only microRNA, you will see soon other papers about microRNA in the context of long COVID. How can we stratify patients, identify their trajectories, and also confirm who is developing ME, which is about 60% of the long COVID at 6 months already, versus those that are not developing ME, but are developing other things, other conditions. And at the same time that we use also another epigenetic mechanism called DNA methylation. And with DNA methylation, we have 1 ME paper that is still is under revision, and 2 that will be resubmit soon on long COVID, where we are presenting that we can predict at the early stage possible, so at the first visit, that who will remain sickly, very sick, even a year following their first recruitment, which means 20-something months since their infection by COVID.
Wow.
And who will recover. And we have very specific markers that can predict the recovery. And of course, what we are looking for is, can we use these new genes indicated in this search as a potential actionable therapeutic target that can apply to those that cannot recover as far. So that's the goal. It's not just an observational studies to predict and confirm, yes, here you have a bad trajectory and you are relatively lucky, you have a better trajectory, but we want to make a difference. So what can we learn and eventually implement a more aggressive approach by looking at different genes that so far nobody really look at them. We more recently for ME, and I will present that in the Invest ME conference later in May, we find a marker associated with the severity of the disease, and we replicate that in a independent cohort from Norway. So French, Canadian, and Norwegian are the same, meaning that this biomarker is really associated with the severity, can explain why women are more affected in severity and frequency. There is a relationship with the estrogen level. And also we find drugs that are FDA or Health Canada clear that we can reposition. And those are very specific, and we did the in vitro testing and confirmed that some of these ones seems to be very promising. So again, that will be my cautions that this won't be applicable to everyone, but I would say reasonably over 50% of ME patients can benefit of such treatment eventually, but I want to remain cautious that we need to do a true clinical trial to really assess the safety and the efficacy of such treatment. But I will let reviewers to evaluate the papers, and we'll see if that paper is getting attraction. Ultimately, I would like that this paper become pivotal and will convince whoever to support the first clinical trial for that using those compounds, so which are well known and relatively cheap compounds, so nothing
fantastic
too esoteric for now.
Can I just ask you to repeat, because it just went by me a little bit fast. You said you found something that explains why women get affected more severely than men. Did I hear that correctly? And can you share a little bit, I guess, without giving too much away, Like in what area, what markers were
Eventually,
showing that?
I will mention that
Yeah.
in due times in the upcoming
Okay.
weeks and months. But this marker is sensitive to estrogens, so which explain that women between 18 to 30 years, okay, will show a more elevated level of that marker, and its elevation is associated with the severity of the symptoms.
Okay.
And if you take some birth pill controls that are enriched in estrogen, it's even worse. Okay.
Wow.
So immediately we can do some counseling and say, okay, can you have other control, either birth pill control without estrogens, okay, or to find other methods, okay. And of course, this is a discussion between the patient and her physician and we respect that, but at least we can put forward something here. And the use of these drugs that are used for other condition, they are well known, they are relatively safe. And again, when we are proposing such a drug, is to use the lowest dose possible. We don't want to treat another condition. We just want to benefit all the off-target effects that are preventing the release of these factors, and we identify the mechanism. So this paper will be really mechanistic. Okay, so we have a lot more details that you may see in many other ME/CFS paper, okay, because this is, I think, where we should go. There's a huge pressure, as you know, to launch different clinical trials, but most of them will end up with some kind of failure that we may be creative enough to rescue at the end of the day and say, oh, finally, when we reanalyze the data, we may say that 10 to 15% of the patient finally responds, but we still don't know. Now we are addressing the problem differently. We find a biomarker associated with the disease severity. We validated that in an independent cohort, which is always demanded but rarely done. And now we identify the cause of this associated with the release of this marker, and we find a drug that can prevent that and can be tested in vitro. So I'm not saying it's perfect, but I hope that this paper will start to become a kind of model to eventually say, hey, we know a lot more. We can propose something that we have the mechanistic approach. We can show you how the medication is working. And from that, we can either develop better medication if we need it, better formulation if we need it, but at least we have the whole mechanism. So even if it's not perfectly working as we think, these medications never been tried in ME/CFS, okay? Never been show up in survey, as far as I know. And even our biomarker never been picked up by other proteomic analysis. So I think it's very promising, but again, I want to be cautious. Let's play on the safe side and let's the field to address that and see how it works. And maybe some individual having ME have been tried for different reasons those medications and say, well, hey, I'm a bit better with that type of drug, or okay, for XYZ reason. But of course, we may find a subgroup of individuals that the drugs won't have any effect because they are not concerned about the mechanism, which is also important why we need to have precision medicine approach and how we stratify patients. We are not stratifying patients just to promote treatment for a subgroup. Everyone is on board. Okay, I really want to make sure, but we want to be efficient and safe when we propose something. And by having this approach based on precision medicine, I think we are de-risking clinical trial. And my dream, personally, is to bring clinical trial in Canada.
Right.
So because we are seeing a lot of clinical trial in many places, rarely in Canada. So I think we have huge population of participants that deserve to be treated and willing to participate. They are very knowledgeable, and I think they can make a difference. So we will work together to figure out something.
Can I just back up one step and get you to share a little bit more about the microRNA research or aspect of your research? Because I think that's the part that is quite different, and that's what you're using to stratify the patients, right? That might lead to the clinical trial. So can you explain to people what microRNA is and some of examples of what you're finding?
Yeah, so let me start saying that for the Nobel Prize of Medicine and Physiology, the two awardees are the ones that discovered the microRNA in 1997.
Wow.
So it's relatively recent. Okay, so and the microRNA are very small, non-coding ribonucleic acid molecule. Okay, so and these ribonucleic acid molecules are not coding for the information associated with the genes to make a protein. Okay,
Mm-hmm.
they are technically and during a long period of time, people say, oh, they are doing nothing.
Right.
Okay,
They were
there's
called junk, right?
junk, and we know
Yeah.
that 98% of the genome is junk. Okay, until that we start to identify different pieces of non-coding RNA. So you have the very small, the microRNA, they are about 19 to 25 nucleotide in length. I remind you that DNA is based on a code of 4 letters, okay? Same with RNA. So, and they are small, but very powerful because um, the one that discovered the microRNA, they understand that when they were produced, they can also associate with messenger RNA, the ones that will produce protein. But when they attach at the end of these messenger RNA, that generate a complex, and that complex do two things. Often it may lead to the degradation of the messenger RNA, so no messenger RNA, no protein. Or simply by attaching, having this complex, it prevents the translation by other protein that we call the ribosomal machinery. And so one microRNA can target up to 200 different genes, and
Wow.
one genes can be targeted by different microRNA. And sometimes in this region that we call the 3' untranslated region, okay, they may have several binding sites for the same microRNA or different microRNA. So of course, if you have 5 binding sites for a same microRNA, this microRNA is elevated, like in ME, that will make a lot more damage, and you are doomed to not produce that protein. So, so very efficient. What is also interesting working with microRNA, and that was part of why I select microRNA when I start the field, they are subjected to very rapid change from the environment.
Ah. So they're not set
and
in stone like genes. They're constantly changing depending what we experience.
Exactly. And
Okay.
we know that what we call epigenetics, okay, is probably more important than genetics. And we know that genetics play a role, and there are family with several cases. But most of the time, people develop ME/CFS without really a history of familial history of ME.
Right.
And is being hit by a bad flu, a bad mononucleosis, a bad COVID, maybe. So different factors or environmental factor like heavy metals, arsenic, and other situation. And all these conditions can modulate your microRNA at some point. And when you hit the jackpot, having the right combination, unfortunately, you will develop ME or some specific symptom like POTS, okay, the postural orthostatic syndrome. There are microRNA that seems to be very specific. We have a project on that. We recently identified 2 microRNA associated with POTS without ME.
Wow.
And 2 others that are only in POTS but with ME. And they are different in some aspect, but also they are targeting the same genes that may involve in the formation of tachycardia. So, which is also reassuring. Okay.
Can I just ask a clarifying question? I think I heard you say there's these 2 mechanisms by which the microRNA downgrades, like either degrades or blocks. Is it always a blocking action, or can it sometimes augment or increase the action of mRNA?
I would say 95% is more toward the degradation.
Okay.
Okay, there are few binding sites that are in the promoter region of some genes. In that situation, okay, they may attract a complex that will promote the expression of a gene, okay, but is a rarer phenomenon, okay. But on the other hand, when you have a microRNA that is going very, very low, the result of this diminution or decrease is that we promote more of the protein because you remove one obstacle or break,
Yeah.
if you wish, okay? So
So it's very
up or down.
complex.
So unfortunately, there is not a single microRNA associated with a disease. So that's why we need to look at a signature or a profile, and that profile can be relatively specific, that now is marking or used as a marker for a disease. So that's why we, using our panel of 11 microRNA, we were able to make sure that at 100% we know who is suffering of fibromyalgia versus who is suffering of ME. And when fibromyalgia is a comorbid condition, we have a kind of composite score. So which is also very important for clinicians to confirm their diagnosis, okay, but also to remove maybe FM participants, okay, from ME cohorts for the sake of finding what is really causing ME, and on the other end is also to address what is causing FM and severity, because there's, as you know, there's a lot of overlap between ME and FM symptoms. So we shouldn't be surprised, but they are quite different also.
Yeah, you've given, I know at conferences, you've given really great examples where two people might look the same, but in fact, their microRNA profiles are very different, and that leads you. And so most of the treatments that are coming from this profiling are drugs that are acting on these genes or mechanisms that the microRNA is impacting, like you're trying to shift it in some way.
We could target the target of the microRNA, okay, and bypass their effect somehow, okay. So let's say that you have a protein that there are several microRNA that are downregulated, and the protein is up, so we can, if it's an enzyme, we may have an inhibitor of that enzyme. But we found recently through our observational study that we're just looking about, now we have hundreds of participants. So we have naive participants, not a single drug. I was quite surprised. It's a very minority. And most of the participants, they are taking 9, 10, up to 12 different drugs, okay, to alleviate most of their symptoms. And by looking about the group having a specific drug plus others versus the others without this drug, we start to find a difference. So for instance, some of the microRNA are very sensitive to specific drugs that are just used to alleviate symptoms. And by combining two drugs, okay, we realize that 7 of the microRNA that are too elevated in a specific cluster of ME can be downregulated.
Wow.
So again, it's an observation. You have also the background of additional drugs minus the drugs of interest. It's not a clinical trial, but we can prove that. And there is some kind of literature about other microRNA that are sensitive to drugs, okay, or natural compounds. So that can be targeted directly by a drug. We have to be careful because, again, one microRNA can target 200 different genes. So if the microRNA is too high, the goal is not to bring it to 0, but maybe just to slightly find the right range. And again, that will be the challenge in the future. If you think about something like diabetes, where glycemia is our reference here. So you know, if you have type 1, you know how many times or when you should give you a shot of insulin. Okay, but without measuring glycemia, okay, you will probably end up in coma or even die. So and even for type 2, where it's not really insulin your solution, you have other drugs that can reduce your glycemia. Okay, you still need to measure your glycemia. So for a chronic disease, we have colleagues that, for instance, through ICanCME, got a new frontier grant where he's developing a rapid method to measure microRNA. So, and eventually, this is still the future. He is just at the proof of concept, but eventually we can have this measurement rapidly from interstitial liquids or blood, and you can even eventually read on your cell phone. So that will be the future when we will know what type of drugs for what group of patients must be done. And we will need to measure the equilibrium because everything is moving. So if you overshoot, you may end up with more complication or side effect that you don't want. But it's true for any other chronic diseases. So the monitoring will be the key. And we have champions that are developing the tools. They just await the right biomarkers. Is it the microRNA? Is it the other peptide proteins? So all in all, I think the next 5 years you will see more solid science promoting mechanism and new targets that are very, very, very promising, more promising than the last 5 years.
Wow, that is exciting. But just before we wind up, can I ask you, I know that you're using this 11 microRNA panel in your research. Are you also hoping or working towards getting it more available so that people can benefit?
Yes, so this is complicated because
sorry, yeah. I'm sure that's an understatement.
Yeah, so the translation from the bench to the clinic, okay, it demands some funding, of course. It demands from people from either from the private sector or philanthropists that are willing to make the test available. When being approached by a different group, but unfortunately not serious one, to really assist us in such a development. So right now, it's my main concern or my burden, if you wish, because I cannot recruit more. I already have 200 people waiting on my waiting list.
Wow, okay.
Which means that we cannot start to recruit before mid-2026 now, okay, to achieve that. And of course, I cannot test non-Canadian, okay, which is not allowed for me for different reasons, including insurance reasons. So we are looking forward to work with colleagues in different countries. So a lot of interest, but nothing concrete at this stage. And I hope that they may listen to your podcast and be motivated to talk to us because the tests are very pragmatic. It can be deployed in any certified diagnostic lab using qPCR.
Okay. So they're easily scalable, let's say.
Exact, but everything has been done under the ISO 13485 certification. My lab is certified. Sorry, we have all the standard procedure that are already written in French and in English. So and probably the future will probably be testing at the commercial level, offering the test in UK and Europe, because they are more open about using tests, even if they are not certified yet, because the government allowed them. So clinician may ask a test that is not yet certified, but which means that the patient, the customer, will pay from his own pocket without any reimbursement. But that generates some results, and why it's admissible in UK and Europe is because they believe about bring a new layer of information, especially for complex diseases where any lab tests are not bringing new data for them. So that bring more information for the sake of information. In Quebec and Canada, we are not allowed to do that because the code that regulate the behavior of clinician are, in Quebec is, I think, Article 42, prevent any clinicians to use a device or a test that has not been received a regulatory approval. In Quebec will be INES, the Center of Excellence, and Canada, across Canada will be Health Canada probably. And they cannot do that, okay?
Okay.
Through the research, we can bring information, but that will remain on the research side and the physician will use his own judgment and professional engagement
Right.
to decide to reposition or not a drugs. So that's why we need to move forward and implement clinical trial in Canada as well with partners with pharma eventually, but using precision medicine principle.
Very exciting. I'm wondering if I can ask you a last question, which is what you're most excited about. Maybe if you go beyond, of course, you're excited about your own research, but if you look at what other people are doing in the world, there's a lot of creative ideas. Where do you think the breakthrough is going to come?
I think the breakthrough will come with different places. Okay,
Yeah.
there's a lot of tools under development in neuroimaging with tools that could have an immediate approval at somehow, although such a tools in neuroimaging will also very expensive, so very unlikely
Yeah.
to be used for clinical trial. But for diagnostic purposes or to really assess additional, let's say, neurocognitive impairment or other things, they may be beneficial for ME and other diseases where cognition is involved. There is a lot of work by Robert Wurst, for instance, in Netherlands about muscle. So muscle
Yeah.
is not well studied. It's not obvious to have access to muscle. Okay, so performing biopsies. I know David Systrom is doing that in Boston. Very demanding. It's hard to have HRB's institutional review board approval for that. But muscles is also affected, as you know. There's muscle pain, but there are also muscle weaknesses that must be addressed, and some patients complain more about those aspects than others. We need also to address the difference in terms of PAM. Okay, as you know, PAM can be triggered by physical exacerbation. You don't need much to achieve that, as well as to have emotional exacerbation or cognitive obsession. I think we need to dig a bit more in those aspects to really make a better understanding of what is happening and how we address that. Can we prevent some symptom? I think it's possible the way that we are dividing our subgroup based on the most debilitating symptoms like dysautonomia and different aspects. But I think the success will come from the converging of different centers willing to share. I think this is what we have seen so far. And we need to work together, make sure that at the end of the day, my goal is simple. If I find something that is useful, must be replicated by others, and I can be able to replicate what others are doing. What we need is more funding, of course, because it's almost a luxury to, at the same time, you develop something unique or different. And I think we need to continue to think outside the box. Well, I think we also to be more mechanistic in our approach to de-risk clinical trial and not for the sake of resisting to develop clinical trial. I think we need to develop clinical trial, but I think we need to be more efficient and having more, let's say, the molecular basis in mind, we will become more successful collectively.
Okay. My very last question is, if people, you've already mentioned how people can find, even join. So people are welcome to join ICanCME. You don't have to be active researcher. You can still participate and contribute.
ICanCME is for all Canadians.
Yeah.
And beyond. So we have international member as well. It's free. So you go to the site, you follow the guidelines. Okay, you applied. And we have a rapid approval process because we know we want to know there's always access to the first pages that are open, but becoming a member allowed you to participate, to eventually be aware about what the different working group. You may eventually even join the working group or join different body of our governance. Okay, so it's not my research network, it's us. Okay, so it's all about us without us. So we truly believe about that, and eventually we need to prepare the next generation. So we need to grow. We start with a few bunch of people, as you know.
Yeah.
Now we are closer to 400 something members.
Wow, that's awesome. That's awesome. last question is how people could contact you, especially if they want to support or donate to your research.
I think the easiest way is to contact your info at ICanCME, okay,
Okay.
.ca. Okay, so all the requests will come to me, and I will put them in contact with our foundation at Saint Justin Hospital.
Perfect. Thank you so much for doing this. I think people are going to be very inspired and heartened by how much research is happening in Canada. I really appreciate it.
Thank you very much. I really appreciate the opportunity, and I wish you all the best.
Thank you. Thanks for joining me on the Dr. Eleanor Stein podcast. I hope you are taking away new strategies and ideas to improve your health and a renewed sense of hope. Join me, Dr. Eleanor Stein, for our next episode. Can't wait? Check out my website for a wealth of free resources.